Hello and welcome. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode 1 of the CMEOCast series entitled Immune Pathways in Systemic Lupus Erythematosus. This podcast series is supported by an unrestricted educational grant from AstraZeneca Pharmaceuticals. I'm Alan Gabowski, professor of medicine at Weill Cornell Medicine, an attending rheumatologist and co-director of the Clinic for Inflammatory Arthritis at Hospital for Special Surgery in New York. I'm joined by my friend and colleague, Dr. Richard Fury, professor of medicine at the Zucker School of Medicine at Hofstra Northwell, and chief of the Division of Rheumatology at Northwell Health in Great Neck, New York. Welcome, Rich.
Thank you, Alan.
In addition to CME and CE credit, today's activity is also eligible for ABIM maintenance of certification points. Once you complete the activity, provide your ABIM ID and birth date when completing the evaluation. CME Outfitters will then submit your mock points. You can also claim this activity as CME for MIPS improvement activities. Over the next 90 days, actively work to incorporate improvements in your practice presented in today's activity. And CMEO will send you a follow-up survey at the end of that time. Upon completion of the survey, CME Outfitters will send you confirmation to submit to CMS, attesting to your completion of this activity for MIPS accreditation. It's an exciting time in lupus with a number of new agents in development. And it's our goal today to help you connect the dots between the immunopathogenesis and emerging agents for lupus. Our learning objective is to identify the immune pathways in SLE that are really informing drug development. Rich, let's start with a discussion of why an overview of lupus is so challenging.
Well, lupus is the most heterogeneous disease there is. And I compare it to snowflakes. Like snowflakes, no two cases are alike. It is the prototypic autoimmune disease. And as mentioned, there's no disease more clinically heterogeneous than lupus. And not only the manifestations heterogeneous, the disease itself is highly variable in activity. The typical course for a patient is chronic with waxing and waning disease activity. And of course, far more females than males will develop lupus. And it's certainly more common and severe in certain racial groups like African Americans, Hispanics, and Asians. As far as the epidemiology, these studies were published several years ago. Emily Summers looked at the epidemiology in the Detroit area and Sam Lim down in Atlanta, and they came out with very similar numbers. And I'm not going to go through all these numbers, but you can see they're color-coded for Michigan versus Georgia. The incidence lies somewhere between scleroderma and rheumatoid arthritis, perhaps about 1/8 the incidence of rheumatoid arthritis. As far as prevalence, you see the numbers. These are the rates per 100,000. And again, between rheumatoid arthritis and scleroderma. And as far as mortality rates, they're actually 5 times greater in males than in females, even though the prevalence is greater in females. And it's certainly higher mortality rates are seen in African Americans compared to Caucasians. And still on the theme of mortality, this study was published from the San Francisco area, and there are actually some surprising results here. Though if you look at the right-hand side and look at the bottom, you'll see the mortality in Asian females and Hispanic females is far greater than in white females. But actually what I found surprising is the mortality rate in Black females seemed to be a little bit less than in white females. Now back to the heterogeneity. There are my snowflakes in the top right. And some of these slides are from my own patients, or some from the ACR and some from the internet. And you see all different kinds of rashes. We see Raynaud's at the top. There's a PET scan of a patient of mine with chorea. I mean, it's always amazed me in lupus how heterogeneous the disease is and how any organ in the body can be affected. And I could put on many more slides. We could fill up about 15 slides with these pictures.
When we train using the older set of the classification criteria, it turns out that there were as many ways of presenting with lupus as there were stories in the Arabian Nights. So your analogy to snowflakes is really quite appropriate.
Now, the heterogeneity, what is the reason for it? Well, a lot of different possibilities. Genetics, epigenetics. We know the pathogenetic mechanisms, as you'll see in a little bit, can be very different. There are different pathways that are active from patient to patient. We see different types of autoantibodies in different patients. Certainly, demographics plays a role, ethnicity and race, and interestingly, socioeconomic factors play a role in the heterogeneity. Now, the heterogeneity can haunt us, makes it very challenging to take care of lupus patients. It makes prognostication difficult, that we kind of have an idea, if a 20-year-old African-American walks through the door with discoid lupus and DNA antibodies, we worry about that patient far more than, say, a 55-year-old Caucasian walking through the door with SSA antibodies. Not that we have a lot of different therapies in our toolbox right now, but which therapy for which manifestation. It certainly made the development of drugs very difficult. Our clinical trials have been haunted, absolutely haunted by this clinical heterogeneity.
And no one would know that better than you, and we'll get to that a little bit later. But we also talk about bench to bedside. Let's go from bedside to bench. Tell us a little bit about the basic concepts and mechanisms of injury in SLE.
Yeah, I mean, this is a little bit simplistic, and I've divided it up into the humoral immune system, cellular immune system, and so forth. But let's tackle autoantibodies. And I have 4 different mechanisms here by which injury can occur in lupus. There can be direct binding of an autoantibody to its target. And some people think this is responsible for central nervous system dysfunction or apoptosis. Now, the next column, the second column, is the classic, what we learn in medical school. And that is immune complex formation, where an antibody, say an anti-DNA antibody, binds to its target DNA. And that immune complex lodges in the kidney, where complement is fixed, and it starts a whole inflammatory cascade leading to kidney injury. The third column, ADCC, stands for antibody-dependent cytotoxicity. And in this model, which is a model of, say, autoimmune thrombocytopenia or autoimmune hemolytic anemia, the warm type, the antibody binds its target. And then that complex is engulfed by a phagocytic cell via an interaction between Fc on the antibody and Fc receptor on the phagocyte. And the last column, CDCC, stands for complement-dependent cytotoxicity, somewhat similar to ADCC, but here the antibody binds to its target, and in this model, a red cell. And this would be a model for autoimmune hemolytic anemia of the cold type. And the binding of the antibody to its target results in complement fixation with destruction of the target. So there are some basic mechanisms where humoral immunity can lead to injury. Then we have a whole variety of cells, and this slide does not do justice to the cellular immune system, but pick your favorite cell or cells, and they are implicated in lupus pathogenesis. Then we have inflammatory mediators. And again, there's a lot of inflammatory mediators, ones that have been in the press recently. Interferons certainly drive lupus pathogenesis. And we have a drug out there that targets BLyS, B lymphocyte stimulator. But you see a variety of other cytokines and the complement system that are also active in patients with lupus. And then lastly, the vasculature. We see thrombosis at the microvascular level, at the macrovascular level, and even sometimes leukoagglutination. Now, with that as background, I'd like to go a little bit more in depth about lupus pathogenesis. And just to remind you, the immune system is composed of the innate immune system and the adaptive immune system. Characteristics of the innate immune system are on the left. It's evolutionarily ancient. In fact, it's found in all plant and animal life. The responses are non-specific, provides immediate defense, not the least bit sustained. And examples would be toll-like receptors, the complement system, or for that matter, neutrophils and macrophages. And if you look at the right-hand side where the adaptive immune system is listed, we see different characteristics. In fact, the adaptive immune system is evolutionarily advanced. It's found in vertebrates only. The responses are antigen specific, and there's memory to mount stronger and stronger attacks via somatic mutations. Examples being B lymphocytes, T lymphocytes, and antibodies. But there's crosstalk between the two. Now, with that as background, here's my rather simplistic rendition of the pathogenesis of lupus. We'll take a genetically susceptible host and expose that host to an environmental trigger. And then in this particular model, the trigger is ultraviolet light, shining down on the skin of a lupus patient, causing apoptosis of skin cells and the release of DNA and RNA. And patients with lupus have a lot of plasmacytoid dendritic cells in their skin. And immune complexes carrying DNA or RNA can enter into the PDC, activating toll-like receptors 9 and 7, respectively. And the result of that is the elaboration of a variety of cytokines, chief of which is the type 1 interferon family. We'll cross over to activation of the T cell, could be by a myeloid dendritic cell, and an interaction of the T cell with a B cell. And there's key interaction via the T cell receptor and the MHC, but there are a lot of co-stimulatory molecules that are key for this interaction. The end result is activation of the B cell, but the B cell requires certain cytokines for its survival, for its differentiation. And those are known as APRIL and BLyS also known as BAFF. And the fate of a B cell is that it can mature into a memory cell, it can mature into a plasma cell. And we know that B cells and plasma cells make antibodies, and in the case of lupus, autoantibodies. And here's the anti-DNA antibody forming an immune complex. We're crossing back into the innate immune system with the activation of complement, which can attract neutrophils, which can damage tissue, and also activate macrophages. And this whole process can start over. That little halo is a DNA net. And here we have immune complexes activating the PDC via the FC receptor. All right, so that I realize is quite simplistic, but I think it gets the point across. And the other point I want to make is that everything that you saw on that slide has been, is, or will be targeted for lupus drug development. So to emphasize, these are the SMART goals. So you need to recognize and accept there's no disease more heterogeneous than lupus. So anybody who wants to challenge me on that, I'll take the challenge. There are multiple immune pathways that are active in lupus as well, as you just saw. And key is that the knowledge of immunopathogenesis in recent years has informed drug development. So lupus has become a very ripe target, and there's unprecedented clinical trial activity underway.
Well, thank you, Rich. This has been a great presentation and really lays the foundation for episode 2 of our series, where we'll begin to look at the safety and efficacy data for agents recently approved or in late stages of development for lupus. In episode 3, we will discuss principles of shared decision-making for patients with lupus. All 3 episodes and a wide variety of education and resources on inflammatory disorders are available on the CME Outfitters Rheumatology Education Hub for both healthcare providers and patients. Now again, a reminder to collect your credit for today's activity. You can click on the link to complete the evaluation, and you'll be able to print your certificate directly from the platform. As a reminder, if you'd like to apply for ABIM Maintenance of Certification credit, provide your ABIM ID and birth date when completing the evaluation, and CME Outfitters will submit your Maintenance of Certification points. Thank you for joining us today.